to all dear students. My today's topic is metabolism of drugs. And yes, this is our third subtopic of our main topic, that is pharmacokinetics. Till now we have discussed about number 1 absorption, number 2 distribution, and this is the third subtopic, that is metabolism. So we'll start the topic. Metabolism, it is also known as biotransformation. When you look at this term biotransformation, you can split this term into two parts. First one is transformation. Transformation means a substance which is changing from one form to another form, that is known as transformation. And bio means a living substance. So biotransformation in total means over here chemical alteration of the drug in a living system. Now what kind of alteration we require? It is conversion of a non-polar substance into a polar substance, or you can say a lipid soluble drug is converted into a water soluble drug. Now a question comes like, why we want to convert a lipid soluble drug into a water soluble drug? So suppose this is our kidney, and as we all know, kidney is made up of millions of small minute units known as a nephron. So just imagine this is your nephron, and beside nephron there is a blood vessel. Now suppose a lipophilic substance is present inside the nephron, and because this is a lipophilic drug, because of its lipophilicity, it can easily cross the barrier and can move into the vascular compartment. Vascular compartment means your systemic circulation. But if in case the drug is hydrophilic in nature, then it cannot cross the barrier. It will stay in the nephron only and get eventually excreted out from your body. Now, and another question comes that why we want to remove the drug out of our body? We have consumed a drug in order to treat a particular kind of disease. So why we want to remove it? The answer for it is elimination. We need to eliminate a drug. Once the drug has produced its desired pharmacological action, after that we need to eliminate the drug out of our body. Now elimination can be done in two ways, that is metabolism and excretion. Elimination means we need to stop the activity of the drug, and we can stop the activity of drug either by metabolism or by excretion, and metabolism and excretion together is known as eliminated. Elimination means we need to get rid of that particular drug. Now the first thing, excretion. Excretion, you people know, we consume food and it will get excreted out from our body. Similarly, when we consume a drug, it is also getting excreted out from our body. Now metabolism, as I have told you, it is a biotransformation. A lipophilic substance is converted into a hydrophilic substance. So metabolism is mainly done so that a drug can be easily get excreted out of your body. So you can say metabolism is a preliminary step for excretion to take place. Okay, so that excretion can take place very easily. Suppose we need to eliminate any lipophilic substance. So first that lipophilic substance should undergo metabolism so that it get converted into a hydrophilic substance, and that hydrophilic substance can easily get eliminated out from our body. Now suppose the drug is already most hydrophilic drug, means already the drug is hydrophilic, so we need not to do metabolism. So in that case, hydrophilic drugs such as streptomycin, neostigmine and pancuronium, these are highly hydrophilic drugs, so they are little or very little biotransformed and then largely get excreted out from our body. Okay, so this is elimination. If anyone asks what do you mean by elimination, don't just say that it is removal of a drug. You should say elimination means it is metabolism plus excretion. So lipophilic drugs will get eliminated out, but hydrophilic substance or hydrophilic drugs will get excreted out. Okay, so being a pharmacology or a pharmacy student, you should know the difference between elimination and excretion. Next, biotransformation of drugs may lead to three circumstances, you can say, like an active drug can be converted into an inactive drug. So most drugs and their active metabolites are rendered inactive or less active, and this is occurring to a 90% of the cases. A second thing that can happen because of biotransformation is active drug can be converted into another active drug. Okay, so many drugs have been found to be partially converted to one or more active metabolite. The effects observed are sum total of that due to the parent drug and its active metabolite. A simple example is diazepam getting converted into oxazepam. So we know diazepam is a CNS depressant. Even oxazepam is a kind of CNS depressant. So whenever you consume diazepam, it will start producing its therapeutic action. And eventually, after production of its therapeutic action, it will get metabolized. So we thought after metabolism the drug will become inactive, but no, this diazepam is getting metabolized into oxazepam, and this oxazepam is a metabolite of diazepam. Even this oxazepam is therapeutically active. Okay, so not all the active drugs are converted into inactive form because of biotransformation, but there are few drugs like diazepam is there which is converted into oxazepam. Even codeine is converted into morphine. It is another example of biotransformation of an active drug into another active drug. Now the third possibility is inactive drug getting converted into an active drug. So few drugs are inactive as such and need conversion in the body to one or more active metabolites, and such a drug is called as prodrug. So the prodrug may offer advantages over the active drug in being more stable, having better bioavailability or other desirable pharmacokinetic properties, or less side effects and toxicities. And a simple example of this is levodopa getting converted into dopamine. So as we know, levodopa is mainly used in the treatment of Parkinsonism. So a person who is suffering from Parkinsonism, what will be the pathophysiology of Parkinsonism? Yes, there will be a reduced level of the neurotransmitter, that is dopamine, and we need to increase the level of dopamine. So as such, if we consume dopamine, in order to increase the dopamine level, this dopamine cannot cross the blood-brain barrier. So in our brain, the level of dopamine will not be increased. But if in place of dopamine, if we consume levodopa, then what will happen? This levodopa, it can easily cross the blood-brain barrier and it will move into the brain. Inside the brain, there will be an enzyme, and that enzyme will convert levodopa into dopamine, and finally this dopamine will increase the dopamine level and will treat the Parkinsonism problem. So the thing to know over here is levodopa is not at all pharmacologically active. Levodopa is not treating the problem, but levodopa which is getting converted into dopamine, that will treat the problem. So we have got an enzyme that will convert levodopa into dopamine. If that enzyme is not there and you are going on taking levodopa, means it will not treat the problem, because levodopa is a prodrug. Levodopa is an inactive drug and it has to be get converted into active drug. So conversion of a prodrug into active drug, or an example over here, that is conversion of levodopa into dopamine, is an example of metabolism. And you should not get confused over this example with the second category, that is active drug converting into another active drug. Here diazepam is converted into oxazepam. Diazepam is not a prodrug, it is an active drug. But here levodopa, it is a prodrug. So there are possibility that an active drug getting converted into another active drug, or an inactive drug, or you can say a prodrug getting converted into another active drug. So we have got three possibilities that may occur because of biotransformation taking place inside our body. Next we will check out sites for metabolism. The primary site for drug metabolism is liver, and other areas where metabolism may take place can be intestine, kidney, lungs, placenta, plasma, and many other areas. Even on skin also metabolism takes place. But to the largest extent, metabolism of a drug takes place in liver. So they are known as hepatic metabolism. Hepatic metabolism means when metabolism of a drug is taking place in the liver, it is known as hepatic metabolism. And if metabolism of a drug is taking place at other areas, not in liver, but means except liver, in any other area, if metabolism of drug is taking place, it is known as, very simple, extrahepatic metabolism. Okay, so we can divide it as hepatic metabolism and extrahepatic metabolism. Hepatic metabolism is metabolism of drug taking place in liver. Extrahepatic metabolism means metabolism of a drug taking place in any organ except liver. Next we will check out the enzymes which are required for metabolism. So we can group the enzymes into two groups, you can say, that is microsomal enzymes and non-microsomal enzymes. Now, what are microsomal enzymes and what are non-microsomal enzymes? Very simple. The enzymes that are found in microsome are known as microsomal enzymes, and the enzymes that are not found in microsomes are known as non-microsomal enzymes. Now, what is this microsome? See, this microsome is another name given for endoplasmic reticulum. Like suppose this is a cell have got a nucleus, mitochondria, endoplasmic reticulum. Suppose this is your Golgi body, this is your liposome. Few enzymes that are present in liver, there are few enzymes present in mitochondria, few enzymes are present in endoplasmic reticulum, few enzymes are present in Golgi body, few enzymes are present in the lysosome, and few enzymes are present in the cytoplasm also. But the enzymes which are found on the endoplasmic reticulum are known as microsomal enzymes. Okay, so microsome is given and means microsome is another name given to endoplasmic reticulum. Now, one question will strike in your mind that why so much importance and why so much VVIP treatment given for the enzymes residing in the endoplasmic reticulum. The answer for that is these microsomal enzymes, or you can say the enzymes which are found in the microsomes, they are easily inducible, whereas the non-microsomal enzymes are not easily inducible. Okay, non-microsomal enzyme you will find in either it may be present in the cytoplasm or in the mitochondria or in the nucleus or in the Golgi bodies, anywhere except in the endoplasmic reticulum. They are known as non-microsomal enzymes, and these non-microsomal enzymes, they cannot be easily inducible. Now, what is meant by this inducibility? We'll check out with a simple example. Here you can see on the left hand side I have made an area specially for microsomal enzyme, and on the right hand side the area is for explanation of the non-microsomal enzyme. Now, suppose there is one person who is consuming warfarin and another person who is consuming heparin. See, both warfarin and heparin are anticoagulant drugs. Okay, so there were two individuals, person A and person B. Person A was consuming warfarin and person B was consuming heparin. Now, the amount of these drugs required for producing anticoagulant action is 100 molecules. Okay, 100 molecules of warfarin required for producing therapeutic action, and 100 molecules of heparin as well for producing its therapeutic action. Now, the metabolism of these drugs are such that in a span of 1 hour, 100 molecules are getting metabolized and the product will be just 50 molecules left. And for doing so, we require 50 enzyme. Okay, so 50 enzyme is metabolizing 50 molecules of heparin. Okay, so you can say one enzyme for one molecule. Okay, one enzyme is metabolizing one molecule of heparin. So here we have got 50 enzymes. So 50 enzymes are metabolizing 50 molecules, and after 1 hour, the 100 molecules are getting brought down to just 50 molecules. And same occurs for heparin as well. Okay, for heparin also the enzyme 50 enzyme are metabolizing 50 molecules. Okay, one enzyme for one molecule here also. Okay, both cases we have got balance. The difference is only in the nature of the enzyme. For the warfarin, the enzyme is microsomal enzyme, whereas for heparin, the enzyme is a non-microsomal. Now, for a normal action of both this warfarin and heparin, we require 100 molecules only. 50 molecules will not produce any therapeutic action. So, it is said that after every 1 hour, that person should consume 50 molecules of warfarin so that the 100 molecules should come back, and those 100 molecules are only required for producing a therapeutic action. If molecules of warfarin are less than 100 means there won't be any therapeutic action as such. And same thing is for heparin as well. So till here the story was going very much parallel, pretty parallel you can say. Now a twist will come. Now suppose both person A and person B both are now suffering from tuberculosis, and for treating tuberculosis both are consuming an anti-TB drug, that is rifampicin. Okay, both are consuming rifampicin. But now what this rifampicin will do for this microsomal enzyme, the enzyme which was metabolizing warfarin, it is getting induced by rifampicin, or you can say rifampicin is inducing this enzyme. Inducing means it is producing induction of that enzyme. Induction means it is increasing the synthesis of the enzyme. So previously the availability of the enzyme was just 50, but because of induction done by the rifampicin, instead of 50, the number has been increased to 90 enzymes. So now 90 enzymes are available for metabolizing 100 molecules of warfarin. So as I have told you, one enzyme for one molecule of warfarin. Now we have got 90 enzymes, and these 90 enzymes, obviously it will cause metabolism of 90 molecules of warfarin. And how much will be left? Yes, it will be just 10 molecules. Okay, now it is means as such, after every 1 hour the person was consuming 50 molecules of warfarin, and here also he consumed 50 molecules, but now the amount left will be just 60, because 40 extra molecules were being metabolized by the 40 extra enzymes because of the enzyme induction done by rifampicin. So it is known as enzyme induction. But in this case, in case of rifampicin, the person who was consuming rifampicin, the enzyme, the metabolizing enzyme is non-microsomal enzyme, so it will not get induced by the rifampicin. Similarly, we'll take another example over here. Now the person is not suffering from tuberculosis. He is consuming another drug such as cimetidine. Okay. Now what this cimetidine is doing to this microsomal enzyme is, it is inhibiting this enzyme. Okay, inhibiting means it is destroying enzymes. Suppose this cimetidine has destroyed nearly 40 enzymes, so left over will be just 10 enzymes. Now what these 10 enzymes will do, as I have told you, one enzyme for one molecule, so just 10 enzymes is there. So these 10 enzymes are able to metabolize just 10 molecules of warfarin. So after 1 hour, the molecules metabolized will be just 10, and 90 molecules will be intact, fresh, available for its action. And after 1 hour, the person consumes 50 extra molecule. So 90 plus 50, it will become 140. So 140 molecules of this warfarin will be highly toxic dose as such. So this is known as enzyme inhibition. But in case of the person B who was taking heparin, here cimetidine is not producing any kind of inhibition to these enzymes. Okay, so this is known as inducibility. There are few drugs that will inhibit the enzyme, or there are few drugs that will produce induction of the enzyme. So we will check out the examples of the drugs that will produce induction, enzyme induction. So we can remember the drugs that will produce enzyme induction with a simple mnemonic, that is PCGPRS. PC means you can remember it from the personal computer or Priyanka Chopra, anything. Okay, PC. GPRS, so you know GPRS is there in your mobile phone. So PCGPRS. Okay, so if question comes, write the examples of few drugs that are producing enzyme induction. So you should remember PCGPRS. So P is for phenytoin, C is for carbamazepine, G is for gracefulvin, P is for phenobarbital, R is for rifampicin, which I gave an example, and S is for smoking. So all these drugs will cause induction of microsomal enzymes. Okay, whatever microsomal enzymes are there, if you are giving these drugs, it will cause induction, means it will increase the synthesis of the microsomal enzyme. So as we have got example for enzyme inducers or induction, we have got examples of few drugs that will cause enzyme inhibition, and you can remember them with the mnemonic civics. You know, in school times we had subjects history and civics, but here the spelling of civics is little bit changed, altered. It should be CIVICS, but I have written here CIVEKC. So civics, you can pronounce this also civics. Okay. So C is for cimetidine, the example which I have shown before. I is for isoniazid, V is for valproate, E is for erythromycin, K is for ketoconazole, and C is for ciprofloxacin. So these are the examples of the drugs. In blue color, enzyme induction, and in red color, enzyme inhibitors. Next, there are two types of drug metabolism reaction. First one is phase 1 reaction, also known as functionalization reaction or non-synthetic reactions. The second one is known as phase 2 reaction or conjugation reaction or synthetic reaction. Now, why phase 1 is known as phase 1 and why the second is known as phase 2? Because 1 comes first and 2 comes after 1. That means any drug that has to undergo metabolism, first it should go through phase 1 reaction and then it should go through phase 2 reaction. The drug cannot move to phase 2 before only. First it should pass the phase 1 reaction and then it should move to phase 2 reaction. Like if you want to take admission in any degree, first you should pass the entrance examination and then you can move to degree college. Okay, so that entrance exam is just like phase 1 reaction and the degree college is like your phase 2 reaction. Okay, now phase 1 reaction is also known as functionalization reaction because a functional group is being generated or being attached to that particular drug molecule. It is also known as non-synthetic reactions because here any new synthesis is not taking place, just one functional group is getting attached over here. Moreover, any drug that goes through a phase 1 reaction, the product whatever is getting, we call them as phase 1 metabolite. Okay, and whatever phase 1 metabolite we are getting, that phase 1 metabolite will now move to the phase 2 reaction. Phase 2 reaction is also known as conjugation reaction. Okay, so conjugation reaction means something is getting joined, something is getting conjugated. So here some endogenous substance is there which is getting conjugated with the phase 1 metabolite. So it is also known as conjugation reaction. And whatever conjugate we are getting, whatever synthesis we are doing, that synthesis means that substance which are producing, it is highly hydrophilic in substance. So we are producing a highly hydrophilic substance is getting synthesized. So therefore it is also known as a synthetic reaction. Okay, so this is the two types of metabolizing reaction, that is phase 1 reaction and phase 2 reaction. A drug which has gone through a phase 1 reaction, the product, that is the phase 1 metabolite, it may be active or it may be inactive in nature, whereas the drug that has passed through phase 2 reaction, to the 95% the drugs, the metabolite or you can say the phase 2 metabolite are inactive in nature. Next, you imagine this brown color box to be your liver. Okay, and as most of the drug metabolism takes place in liver only, so suppose this is a liver and a drug has been entered into the liver. So in the liver, first phase 1 metabolism will take place. After completion of the phase 1 metabolism, the phase 1 metabolite, if the molecular weight is less than 300, then it will move to the kidney and then eventually excreted out via urine. But if the molecular weight is more than 300, then they will move to your gallbladder and eliminated out from the body via bile. Okay, but after completion of phase 1 reaction, still the drug has not removed out from the body, still it is present inside the body, then that phase 1 metabolite will now enter into phase 2 reaction. Okay, and after completion of phase 2 reaction, if the molecular weight is less than 300, then it will move to the kidney and finally eliminated out via urine. Or if the molecular weight is more than 300, then it will move to the gallbladder and then eliminated out via bile. Okay, so after completion of phase 1 reaction, drug may or may not get eliminated out from the body. But after completion of phase 2 reaction, sure and sure the drug should get eliminated out from our body. It may be via the kidney or via the gallbladder. Next, we have got 5 types of phase 1 reactions. They are oxidation, reduction, hydrolysis, cyclization and decyclization reaction. Phase 2 reactions are of 7 types and they are glucuronide conjugation, acetylation, methylation, sulfate conjugation, glycine conjugation, glutathione conjugation and lastly ribonucleoside or nucleotide synthesis. So we will check out all these reactions one by one. So starting with phase 1 reaction, the first one is the oxidation reaction. So this reaction involves addition of oxygen or negatively charged radical or removal of hydrogen or positively charged radical. Oxidations are the most important drug metabolizing reactions. Oxidase is the enzyme which is required for oxidation, and we have got nearly 3 types of oxidase enzymes such as mixed function oxidase, monooxidase and hydroxylase. Various oxidation reactions are such as hydroxylation, for example phenytoin getting converted into hydroxyphenytoin. Here what kind of enzyme it might be, what kind of oxidase it might be? Yes, we have got producing hydroxylation, so obviously it is hydroxylase enzyme. Next, dealkylation, codeine getting converted into morphine. And next we have got example S oxidation. here cimetidine getting converted into cimetidine sulfoxide. Okay, so cimetidine into cimetidine sulfoxide is an example of the monooxidase enzyme, and the dealkylase, that is codeine getting converted into morphine, it is an example of mixed function oxidase enzyme. Okay, so this is regarding the oxidation reaction. Plus one more thing that you should know is oxidation reactions are mostly carried out by a group of monooxygenases in the liver, which is the final step involved in cytochrome P450 hemoprotein, NADPH, cytochrome P450 reductase and molecular oxygen. More than 100 cytochrome P450 isoenzymes differing in their affinity for various substrates have been identified. So this all was regarding the oxidation reaction. Next we will check out regarding the reduction reaction, and it is quite opposite of oxidation reaction. So here basically it involves addition of hydrogen or positively charged radical or removal of oxygen or a negatively charged radical. So this reaction is a converse of oxidation and involves cytochrome P450 enzymes working in an opposite direction. So drugs primarily reduced are chloral hydrate, chloramphenicol, halothane, warfarin and so on and so forth. Many other examples are also there. Third reaction is hydrolysis, and the name only says everything. We will add water and we will do the reaction. So cleavage is cleavage of drug molecule by taking up a molecule of water. So an example is ester, to which if we add water, so in presence of the enzyme esterase, it is getting split into acid plus alcohol. Similarly, amides are hydrolyzed by amidase and polypeptides are getting hydrolyzed by peptidase. Okay. Next, we have got cyclization reaction. So this is the formation of ring structure from a straight chain compound. Example is proguanine. Next is the last one is decyclization reaction. The name only says everything. This is opening up of ring structure of cyclic drug molecule. For example, barbiturates, phenytoin. This is generally a minor pathway. So with this we have completed the phase 1 reactions, and now we'll jump to phase 2 reaction, also known as synthetic reaction, also known as conjugation reactions. So these involve conjugation of drug or its phase 1 metabolite with an endogenous substrate, generally derived from carbohydrate or amino acid, to form a polar, highly ionized organic acid which is easily excreted in urine or bile. Conjugation reaction have high energy requirement. Now one by one we will check out all the 7 types of the synthetic reactions. So the first one is the glucuronide conjugation. This is the most important synthetic reaction which is carried out by a group of enzymes known as the UDP, glucuronosyl transferases. Compounds with a hydroxyl or carboxylic acid group are easily conjugated with glucuronic acid which is derived from glucose. Examples are chloramphenicol, aspirin, paracetamol, lorazepam, morphine, metronidazole and so on and so forth. Not only drugs but endogenous substances like bilirubin, steroidal hormones and thyroxine utilizes the same pathway. So this glucuronidation increases the molecular weight of the drug which favors its excretion in the bile. Okay, so this was regarding the first. Next, the second one is the acetylation reaction, and the enzyme involved over here is the N-acetyl transferase. So we are transferring an acetyl group. So compounds having amino or hydrazine residues are conjugated with the help of this enzyme. Examples of drug includes sulfonamides, isoniazid, PAS, that is para-aminosalicylic acid, dapsone, hydrazine, clonazepam and procainamide, and various other examples are also there. Next reaction is methylation reaction, and the enzyme required is methyl transferase. So we are transferring a methyl group. The amines and phenols can be methylated. Methionine and cysteine, they are acting as methyl donors. Example includes adrenaline, histamine, nicotinic acid, methyl dopa, captopril and so on and so forth. Next reaction is sulfate conjugation reaction, and the enzyme required over here is sulfotransferase. So basically the phenolic compounds and steroids are sulfated by sulfotransferase enzyme. Examples of drug includes chloramphenicol, methyl dopa, adrenal and sex steroids. The next reaction is glycine conjugation reaction. So salicylates and other drugs that have got carboxylic acid groups are conjugated with glycine, but this is not a major pathway of metabolism as such. Next type of reaction is glutathione conjugation reaction, and the enzyme involved over here is glutathione as transferases. So forming a mercapturate is normally a minor pathway. However, it serves to inactivate highly reactive quinone or epoxide intermediates formed during metabolism of certain drugs. A very simple example is paracetamol. See, one or the other day of your life you have consumed, means till date in your life, one time at least you have consumed paracetamol. Okay. Now we'll check out how paracetamol will get metabolized. First, this paracetamol will undergo the phase 1 reaction, and in phase 1 it selects the oxidation reaction. So paracetamol undergoes oxidation reaction, and the phase 1 metabolite will get is epoxide. Okay, the name of the phase 1 metabolite of paracetamol is epoxide, and this metabolism is taking place in liver, and epoxide is very highly toxic metabolite, and if this epoxide is present in our liver, it is likely to cause damage in the liver. So it is said that you should not consume paracetamol too much because it will cause a liver damage. Okay, and we need to protect our liver. We need to protect our liver from the phase 1 metabolite, that is epoxide. So for that we are making use of this glutathione conjugate. Means glutathione is already available in our body. So that glutathione is getting conjugated with the epoxide, and then it is getting removed. Means that epoxide along with this conjugate, it is getting removed out from our body. Okay, so for metabolism of paracetamol, the phase 1 reaction it is undergoing is the oxidation reaction, and in phase 2 it is undergoing glutathione conjugation reaction, and then ultimately removed out from our body. The last reaction is the ribonucleoside or nucleotide synthesis. This pathway is important for the activation of many purine and pyrimidine antimetabolites used in cancer chemotherapy. So these all regarding the conjugation reaction. One important thing you need to know regarding this glucuronide conjugation reaction, and that is the enterohepatic cycling. So suppose this is our liver. Okay, in the liver a drug is approaching the liver, and means this drug is nothing but your phase 1 metabolite only, and in the liver you have got the enzyme, that is UDP glucuronosyl transferases, and what it will do, it will conjugate this liver with the glucuronic acid. Okay, now what will happen to this conjugate? This conjugate, either with the help of a transporter, that is OATP, organic anion transporting peptide, it will transport this drug glucuronic acid conjugate via the bile. It will move into the gut. Okay, so whatever drug it was getting conjugated in the liver, with the help of OATP transporter, with the help of a bile duct, it will be moving into the gut. Okay, this is one possibility. Another possibility is this conjugate, it may enter into the systemic circulation, and with the help of the OATP transporter or with the help of the glomerular filtrate, this conjugate may enter into your kidney. Okay, so we have got two possibilities of this drug glucuronic acid conjugate. Okay, please remember we are talking about the glucuronide conjugation. A little bit more information regarding this glucuronide conjugation. Whenever the phase 1 metabolite drug is been moving into the liver, with the help of the UDP enzyme, it is getting conjugated with the glucuronic acid, and that drug glucuronic acid conjugate, it may move to the gut or it may move to the kidney. There are two possibilities. Okay, if this conjugate is present in the kidney, then via urine it will get eliminated out from our body. Okay, and this is what we want. From after phase 1, if the drug is still remaining inside our body, then after phase 2 it should get removed out from our body. Okay, so if it is present in the kidney, it can easily get eliminated via urine. If it is present in the gut, Gut means our intestine. So in the intestine we have got an bacteria, that is bacterial deconjugases, and the name only says deconjugates. It will cut off the conjugate drug, and glucuronic acid conjugation will be broken down and the drug will be freed off. Okay, so when this complex is present in your gut, the one possibility is this conjugate entirely it may get excreted out via fecal matter, or else when this bacterial deconjugase acts on it and the drug is been removed from that glucuronic acid, so this drug independently or individually or lonely it will get removed out from our fecal matter, or else, and another possibility is the drug it may not get removed out, but it may get flowed out with the help or via the portal vein, and it may re-enter into your liver. Okay, and after re-entering into your liver, it will again acted upon by the UDP enzyme and it will form the conjugate, and again the cycle will continue. So this is known as enterohepatic cycling. Okay, and because of this enterohepatic cycling, it will prolong the action of the drug. Example of the drugs that may undergo enterohepatic cycling are phenolphthalein and various oral contraceptives. Okay, so this is an extra thing you should know regarding this glucuronide conjugation reaction. Next, the last topic of our metabolism is the first pass metabolism, also known as the pre-systemic metabolism. I know you people know this thing very well, but again we should revise the thing. So this mainly refers to, yes, the people know it very well, this refers to the metabolism of the drug during its passage from the site of absorption into the systemic circulation. Okay, so in the liver the drug will appear, and few drugs may undergo metabolism in the liver as such. So before distribution only the drug is getting metabolized in the liver. So that's why it is known as first pass metabolism, or you can say the pre-systemic metabolism. Okay, and whatever left over will now enter into the systemic circulation. So we have got hepatic extraction ratio, ER liver. Hepatic extraction ratio means it is a fraction of the absorbed drug prevented by the liver from reaching into the systemic circulation. So what much amount of drug is getting extracted out by the liver is known as the hepatic extraction ratio. And this hepatic extraction ratio can be calculated by the formula ER equals to CL liver divided by the hepatic blood flow. CL means the drug cleared off from the liver. Accordingly, the systemic bioavailability, that is F, of an orally administered drug will be F is equals to fractional absorption into 1 minus extraction ratio. Okay, so by this we can calculate what is the extent of the first pass metabolism, and obviously we need to calculate the hepatic extraction ratio when we are taking any drug via enteral route. Okay, if we are taking any drug via parenteral route, we may not require calculation of the hepatic extraction ratio, because the drug will not move to the liver as such. When you are taking any drug via enteral route, means via oral or via the rectal route, obviously drug may enter into the liver, and in the liver the drug will get extracted means it will get metabolized by the liver, and little bit will be left over to be moved to the systemic circulation to undergo distribution. Okay, next we'll check out few attributes of drugs with high first pass metabolism, means what things we should take into consideration whenever you are taking any drug via enteral route and that particular drug have got very high level of first pass metabolism. The first thing that you should keep in your mind is oral dose is considerably higher than sublingual or parenteral dose. Obviously, suppose any person is suffering from some so and so form of disease, and for treating that disease we require 100 molecule of drug to be acted upon at that particular organ. Okay, so suppose we are taking any drug via oral route, and that drug have got very high first pass metabolism, and almost 70 molecules are getting metabolized in the liver, and just 30 molecules are been available at the target area, but that 30 molecules will not produce any action. So we should take almost 170 molecules of that drug, so that some 70 molecules will get metabolized in the liver, and 100 molecules which is required will be presented at the site of action. But if you are taking the drug via parenteral route, then you can take just 100 molecules only, because that 100 molecule will not move to the liver. In that case, if you are taking 170 molecule via parenteral route, means 170 molecule will be presented at the target area and it may lead to toxic effect. So any drug which have got high first pass metabolism, and if such drug you are taking orally, then you need to consume a higher dose as required. But when you're taking the same drug via another route like sublingual or parenteral route, so no need of taking so much higher amount of drug. Just take whatever amount of drug is required, or you can say therapeutically effective drug is required. Next thing is, there is marked individual variation in the oral dose due to differences in the extent of first pass metabolism. Okay, now we know one person is different from another individual. Okay, so individual to individual variation in metabolism do occur. In one individual, he have got high number of liver metabolizing enzymes or hepatic metabolizing enzyme, and another individual may not have that much amount of hepatic metabolizing enzyme. Okay, so the person who have got large amount of enzyme or large amount of metabolizing enzyme in the liver, in that individual he may require higher dose, but another individual that have got not that much, just minimum amount of hepatic metabolizing enzymes, that individual may require lesser dose. Okay, so individual to individual the enzymes may vary, and accordingly we should give the dosing regimens. Next, oral bioavailability is apparently increased in patients with severe liver disease. Okay, now suppose there was an individual who was suffering from some XYZ kind of disease, and for treating that disease he was continuously taking some kind of medicine, some kind of drugs. Okay, and that person was alright. That drug what he was consuming for treating that kind of disease was having a very high first pass metabolism. Okay, so instead of 100 molecules, the doctor was prescribing 150 molecules, so that suppose 50 molecules were getting metabolized in the liver and 100 molecules will be available for action. Okay, so till now that person was completely alright. Now that person is suffering from some kind of liver diseases, and because of which the liver is not functioning properly. The liver is not functioning properly, that implies the liver is not able to metabolize the drug properly, and in that individual is again he is taking 150 molecules, means now instead of 50 molecules, now the liver is not working properly. So instead of 50 molecules, now the drug is metabolizing just 10 molecules, and instead of 100, now 140 molecules has been presented at the site of action, and because of which it may lead to a toxic effect of that drug. So if a person is suffering from some kind of liver disease, then in that case you need not to give so much higher dose of the drug. Okay, so that implies oral bioavailability is apparently increased in patients with severe liver disease. So in this case you need to give a lesser dose of the drug. Lastly, oral bioavailability of a drug increased if another drug competing with it in first pass metabolism is given concurrently. A very simple example is chlorpromazine and propranolol. So you can say a competition occurs between chlorpromazine and propranolol. So liver will be like whether I should metabolize chlorpromazine or whether I should metabolize propranolol. So both will be competing, and we cannot predict that whether chlorpromazine will produce the action or it will get metabolized, or whether propranolol will produce the action or will get easily metabolized. So in this case we cannot predict the response as such. So we should not give such kind of drug concurrently. Okay, so with this I have completed the discussion regarding the metabolism of drug. I hope you understand this topic. Thank you.